Good afternoon. Good afternoon, everybody. We're gonna get started. Thanks so much. Thank you so much for joining us today. I'm very happy to see so many faces at this convening here and online. My name is Matthew Eisenberg. Can you hear me okay? All right, not too loud. I'm the director of the Center for Mental Health and Addiction Policy, or CMAP, as we call it. And I've only been in this role for the past 2 years. However, our center has been around for 10 years. This is the 10th anniversary of the Center for Mental Health and Addiction Policy. Our work has always been about helping people with mental health and substance use disorders through policy research. Mental health and substance use disorder are bipartisan issues affecting all communities across the country. With today's event focused on policy and mental health is one way we share our work with you and spark discussions that matter. I'd like to express our thanks to the Provost's Office, the University Nexus Award Initiative, the Bloomberg American Health Initiative, and the de Beaumont Foundation for their generous support of our center. And a big thank you to Sam Rosenberg, the HBC team, the CMAP team, the leaders of and colleagues in our two sponsoring departments, the Department of Health Policy and Management and the Department of Mental Health. It's now my pleasure to introduce Dr. Keisha Pollack-Porter. She is the Bloomberg Centennial Chair and Bloomberg Centennial Professor in Health Policy and Management. Dr. Pollack-Porter is an internationally known expert in health and all policies, and I'm confident you'll find her insights very valuable. So thank you, and please join me in welcoming Dr. Pollack-Porter.
Hi, good afternoon, everyone. Oh, good afternoon. Thank you. Thank you. Thank you so much, Matt, for that introduction. I hope to live up to your comments on providing valuable insights to everyone today. Thank you to the center and to everyone for arranging this event today. I want to begin my brief comments with a story. One summer when I was in college, I worked at a local Head Start in New York. Head Start programs are funded by the federal government, and they prepare 3- and 4-year-old children from low-income families to succeed in school and in life beyond school. At that Head Start, I met a boy, 3 years old. His name was Jewel, and I remember because his name was so unique. And Jewel would arrive each day to Head Start, where he would have his meals, receive physical and mental health care, see the social worker, and play safely with his friends. For Jewel, Head Start, which is a key component of the US education system, was a place where his health needs were met. In Head Start, health was intentionally part of the schools, and investments were made to ensure that health was supported and not harmed. It is widely recognized that efforts to improve health in the US have traditionally looked to the healthcare system as a key driver of health and health outcomes. And because of that, as you all know, the US spends a lot of money on healthcare, and we know that we don't always see the outcomes that we desire. And I truly believe in my work has moved forward in advancing the ability for every single person to be as healthy as possible. And achieving a world where health is attained by everyone requires public health to partner closely with non-health sectors, hence health in all policies. I spend a lot of time engaging with policymakers and decision makers from other sectors to help them understand how their decisions can impact health. I work with individuals in education, in transportation, housing, energy, planning. And in promoting health in all policies, or the acronym is HIAP, we have a collaborative approach that articulates health considerations into all aspects of decision-making. HIAP is also a data-driven approach grounded in evidence and science about what works. And it's about changing systems and processes and structures so that health can be routinely considered so that we see the health gains and not the harms. And HIAP can effectively help to achieve that goal of health for all by addressing those structural drivers of health. There are examples from around the world of how health in all policies has really been advancing health and has improved health and well-being and generated economic savings for communities. Let me give you an example. One way of operationalizing health in all policies is by using a tool called the Health Impact Assessment. This is one of my areas of expertise. And there was an HIA that was conducted decades ago of a new building that was going up in a community in California. This building was for seniors and it was planned and actually adjacent to a really busy highway. The analysis that was done in this health impact assessment identified a number of potential ways to modify that design to improve health and not to harm health. Think about the potential impacts of noise on sleep and how that connects to mental health. Or think about the air pollution or the contamination that individuals would be breathing in just because of how their windows were placed. This HIA helped to lead to the design of the building that included windows being moved to the other side, did not increase the cost at all, and adding some sound barriers to help to reduce those potential impacts on mental health of the seniors in the building. Analysis that was later done of the healthcare utilization for the seniors in this building showed declines prior to when they had moved into the building. This example just shows by working with developers, policymakers, and importantly, the community, the residents in that building, the building was able to be designed in a way that promoted health, that promoted emotional health, mental health, physical health, instead of harming health. I'm thrilled that we're here at this meeting today because health in all policies is a strategy. It's an approach that can be implemented widely. And despite interest in the US, there are some barriers. Most importantly, we understand that there are barriers to working together. We still see silos. And we know that we in public health need to do a better job of articulating the co-benefits of health in all policies to our colleagues in other sectors. Better articulating the economic impacts and the health benefits for all individuals. And I believe, though, once we work through these silos and learn how to communicate these messages effectively, we can achieve that goal of health for all. We can achieve building effective relationships and partnerships that are authentic and that address multiple sectors across, address the goals of multiple sectors. There are many tools out there, and I'm sure you'll hear some today. But one of the things that I want to highlight as I wrap up my comments is that health is foundational to every single issue. Unhealthy children cannot effectively learn in school. Unhealthy adults cannot be a productive part of the workforce. The health and security of this nation can be influenced by how we in public health partner with other sectors to mitigate health harms and promote health benefits. We can work across these sectors, the same sectors I mentioned earlier, and identify the ways that we can promote mental health, physical health, and other aspects of well-being. Thank you for inviting me to make these opening remarks. I am excited for the conversation that we're about to listen to. Let me now turn the mic over to Dr. Catherine Ettman, who's an assistant professor in the Department of Health Policy and Management, which is the department I have the privilege of chairing, to introduce the panelists. Catherine.
Thank you, Dr. Pollock-Porter. My name is Catherine Ettman, and I am an assistant professor in the Department of Health Policy and Management here at the Bloomberg School of Public Health. I started my career in politics, so in some ways, today is a dream realized for a younger version of myself who worked on Capitol Hill. Thank you all for coming today, and thank you to audience members watching online. I would also like to thank Sam Rosenberg, the CMAP team, the HPM communications team, the de Beaumont Foundation, and the Nexus Award for making today possible, as well as the Bloomberg American Health Initiative. Our goal for this event is to discuss the upstream drivers of mental health and to consider policies across sectors that can improve population mental health. The goal is to highlight areas of shared value. Our work has identified a range of assets that contribute to mental health. These include financial assets, physical assets, and social assets. Policies that improve access to these assets can, in turn, improve mental health. Our work has also highlighted that mental health is a bipartisan issue. That is, we have found no significant difference in the prevalence of reporting symptoms of depression or anxiety across political parties. This is also true across Americans who sadly report experience with personal loss due to the overdose crisis. In this way, we hope that mental health can be a topic that unifies different groups and that inspires us for shared action to become as healthy a nation as possible. Here's our roadmap for today. We will first hear from each of our panelists and then move on to question and answer. For Q&A, we invite you to please take out your phones, put on the camera, and find that QR code. You can submit questions throughout the panel, and my colleagues, Dr. Eisenberg and Sam, will be monitoring the Q&A. They will be sending me questions via text, so that is why I will be checking my phone. So without further ado, it is my honor to introduce our panelists. First, we have Dr. Ruth Shim. Dr. Shim is the Luke and Grace Kim Professor in Cultural Psychiatry and Professor of Clinical Psychiatry in the Department of Psychiatry and Behavioral Health Sciences at the University of California, Davis. Dr. Shim's research focuses on mental health disparities, inequities, and she provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment Clinic. Among her many accomplishments and leadership titles, she is co-editor of the books The Social Determinants of Mental Health and Social Injustice and Mental Health. I have long admired her work, and it is a true privilege to have her here speaking today. Next, we have Dr. Sally Satel. She is a senior fellow at the American Enterprise Institute and a practicing psychiatrist. She also serves as a lecturer at the Yale University School of Medicine and medical director at a local methadone clinic in Washington, D.C. Her research focuses include mental health policy, transplant policy, and political trends in medicine. Dr. Satel has testified before Congress on mental health policy, and she has written widely in academic journals and magazines. Her publications include the following books, which I will read off: PCMD, How Political Correctness is Corrupting Medicine, The Health Disparities Myth, When Altruism Isn't Enough, The Case for Compensating Organ Donors, and One Nation Under Therapy, co-authored with Christina Hoff Sommers. Her recent book entitled Brainwashed, The Seductive Appeal of Mindless Neuroscience with Scott Lilienfeld was a 2014 finalist for the Los Angeles Times Book Prize in Studies. Dr. Satel and I met almost a decade ago, and I have learned from all of our conversations, and I look forward to her remarks today. Next is Hannah Wesolowski. She leads NAMI, the National Alliance on Mental Health and Illness. She leads NAMI's National Government Relations Policy and Advocacy team. She came to NAMI in 2017 as Director of Field Advocacy before becoming Chief Advocacy Officer. She serves on NAMI's executive team, and she's a frequent spokesperson for the organization, appearing on C-SPAN and is frequently quoted in outlets such as the New York Times, Washington Post, Political, Los Angeles Times, and many others. Before joining NAMI, she spent 5 years at the Public Affairs Council, and she previously led public advocacy efforts at the American Speech Language Hearing Association and the American Institute of Architects. Finally, and then I will stop reading to this group and we'll have a great conversation. Dr. Brian Castrucci is the President and Chief Executive Officer of the de Beaumont Foundation. Dr. Castrucci has authored nearly 100 peer-reviewed articles, cited more than 4,000 times, and he has co-edited 8 books. His insights have been widely shared through many outlets, such as the Washington Post, CNN, The Hill, Stat News, The Daily Beast, CNBC, as well as interviews with the New York Times, Associated Press, Political, MSNBC, NPR, BBC, and Fox News. Additionally, he's a regular contributor to Forbes.com. Before joining the de Beaumont Foundation, Brian spent a decade as an applied epidemiologist. He proudly explained today he is an epidemiologist first and works at a foundation second. And in this role, he served in leadership positions at state and local public health agencies. And I do want to note that the de Beaumont Foundation is a co-partner in the CLIMB study, which is an 8-year longitudinal cohort that I lead, and I collaborate with many in the audience today. It's so good to see you here. And this study aims to cover trends in mental health, economic policy, and policy preferences in the United States. And Dr. Castrucci has contributed many ideas. He's been a key collaborator on the project, including contributing survey questions, co-authoring articles, and helping with our dissemination efforts. So we're really thankful for your being here today. So now I will ask each panelist one opening question, and then we will lead into our Q&A. So please remember to go to the Slido. And my first question will be for Dr. Shim. So Dr. Shim, Thank you for leading some of the country's foremost writing on the social determinants of mental health. She literally wrote the book on social determinants of mental health. Can you please summarize for us the evidence around upstream factors that shape mental health?
Absolutely. And thank you, Dr. Edmond, for this incredibly kind invitation. I do think of the panelists, I came the farthest to be with you all today, and I'm really pleased. I wouldn't miss it for anything, so I'm glad to be here. So it was probably about maybe 15 years ago that thinking about the social determinants of mental health, I had done my residency training. I was ending my residency training. I was taking care of people with very severe mental health problems. And I was noticing that no matter what treatments I provided, depending on where the hospital was located that I was treating people in, I was seeing very, very different outcomes. And the providers were the same, the treatments were the same, but the location was the determining factor for why we were seeing all of these terrible outcomes. I was talking with Dr. Ettman about how people like Dr. Sandro Galea and Dr. David Satcher and Dr. Lynn Todman were at that time just starting to articulate that there is something called the social determinants of mental health, these societal and external forces that are leading to these poor outcomes that we're seeing that have really nothing to do with neurobiology and nothing to do with brain chemistry, but really have everything to do with what are the environmental factors that are contributing. And that very much resonated with me because my residency training, which was a really exceptional residency training in psychiatry, was all about risk factors and identifying risk factors. And if you identify a risk factor, then you can maybe prevent the development of that disease. And I was very interested in prevention. And what I was starting to hear in people talking about the social determinants of mental health is it's not enough to intervene at the level of the risk factor. You're actually intervening too late. And so I started looking into and trying to understand what is actually happening before the risk factor. What's the context that's being set further upstream from the risk factor? And these are things that have been articulated many, many times before. Bruce Link and Joe Phelan called them the fundamental causes of disease. And Sir Michael Marmot and Sir Jeffrey Rose called them the causes of the causes. And further upstream from the risk factor is actually the social determinants of mental health. So these things like adverse childhood experiences and mass incarceration and unemployment and underemployment and job insecurity and poverty and income inequality and transportation insecurity and access to healthcare and climate change and neighborhood disorder, and I could go on and on and on. These social determinants of mental health were setting the context for the development of the risk factor, which then led to poor mental health outcomes and mental health inequities between certain populations. But in thinking about this work and spending a lot of time trying to gather the evidence around these social determinants of mental health, I also came to understand that if you're intervening at the level of the risk factor, if you're intervening at the level of the social determinants, you are still intervening too late because there is actually context that happens even further upstream that is setting the stage for the development of the social determinants of mental health. And those things all the way upstream were what we might refer to as the causes of the causes of the causes. Those things are social injustice. And other people refer to these things by many, many terms, like we could call them structural determinants of health. We could call them unfair and unjust distribution of opportunity. There's many, many names. But under all of that, what's driving these structural determinants, what's driving all the way upstream are two very fundamental policies. And I'm almost done, I promise. I'm gonna wrap it up. Two very fundamental policies, two very fundamental issues. Social norms, or the beliefs we have in society about who in our society is worthy of value and who is less worthy of such value, who in our society deserves advantage and who is less deserving of advantage. And pay attention to that word deserving because it's going to come back over and over in this discussion. And then based on those decisions about who is deserving and who is less deserving, what are the public policies or the laws that we pass that reflect those belief systems? because those laws that we pass then create unfair and unjust distribution of opportunity, which set into motion the social determinants of mental health, which then lead to the risk factor, which then leads to the poor outcomes. So then the work becomes, how do we intervene at the level of our social norms and our public policies? And when we think particularly about people with mental illness, they are people we tend to think of as less deserving. We tend to think of them as getting their illnesses because they are weak, because they don't have willpower, because something is wrong. We have so much stigma about people who have mental health problems. And based on those belief systems, we have passed abysmal laws, both in the mental health care sector, but also generally, that unfairly penalize people that have substance use disorders and serious mental health problems. So I'll stop there because I'm going to continue, and I look forward to the rest of the panel discussion. But that's a little summary of the research.
Thank you. So Dr. Satel, we've just heard about some upstream factors that we know contribute to mental health. And I'm curious to hear about your experiences both as a physician and a researcher, particularly on what individuals can do and the role that the individual plays, either the patient or the provider, in shaping mental health outcomes.
Well, that was a really eloquent and encapsulating summary of all the, what I would almost call the external locus of control. But as a clinician, and this is complimentary, it's certainly not either or at all, but as a clinician, you know, you're at the internal locus of control. It doesn't mean you don't recognize the constraints and challenges that patients face because they live in terrible housing where no one locks no one comes to fix the lock. So when they go out, someone comes in and takes their, possessions, or folks who make phone calls all the time to go to a free dental clinic and no one picks up the phone. I mean, this is all important stuff. I have to admit, I don't take care of the details. That's what the counselors and sort of social work folks are for, but it's important that I understand those factors so you have a better understanding why, for example, their attendance at the clinic isn't as good. In a methadone clinic, that really matters. So, but I would say then so again, my job, and especially if you're working with people with addiction, but really anyone who has behavioral problems, is to try to harness that internal locus of control. What can they do? And one of the most important things that I've noticed all these years, I used to work at a VA hospital where I noticed this. I see this in a methadone clinic. I see this everywhere, is that people have to work. That work is the best therapy there is for folks. And it, the longer you don't work, the longer your skills atrophy and your confidence erodes, and the more reluctant you are to get back into the system. And so that is actually one of the big sort of agenda items, is getting folks, if it's a methadone clinic, obviously they have to stabilize first, but that's the whole point of methadone anyway. It's just to help people stand still so they can kind of reclaim their life. And if they don't have, some people have skills they can sort of re-excavate. Others, sorry about this, I hear a funny noise. I don't know if anyone else knows, but and others need to be, channeled into more vocational kinds of things. But to me, that is just one of the most important things. And often what gets in my way is that I would invoke disability policy, stipulate everyone's well-meaning, but I see both. I see people who really do need that kind of assistance and they can't get it no matter what they do, and that's frustrating. But I also see people who are on disability and it just took them out of the workforce. It frankly, it reified the fact, or convinced them that whatever mental health diagnosis they were given, and half of them don't have it now by the time I'm seeing them, is what's keeping them from being unproductive. I don't even care if it's a job. I want people to be productive and engaged and be a role model for their kids, and have a purpose and have a social network that's at work, and not also just in their neighborhood, because that's all their drug using friends are there. And so that's something that I would kind of focus on. I'd also focus on, we have a big problem in the mental health workforce. That's true. But I've seen a lot of misdiagnosis. I've seen people given labels that they don't have. They're suffering from demoralization, a lot of them more than anything, which is not to say mental health is very real. And you could have a whole different discussion if you're talking about the severely mentally ill. But so many of the folks I deal with they're not bipolar, and they're being given these medications, not like RFK, but I mean, they've been given all for medications, they save people's lives, but I like to see them, more focused on the person in their context, and of course, whatever, let's say more biological condition they might have, but in their focus as well. And sometimes you do need medications and sometimes you don't. If you can manage to help them and help them manipulate their environment and also help them do that, because there's just so much an individual can do. But to me, the ultimate goal is to get people to be productive.
Thank you. So we've heard a little bit about how structural factors shape health outcomes, and we appreciate these comments about what individuals themselves can do. And Hannah, I'm curious to hear from your perspective, what has worked well in a policy perspective. So what strategies have you seen to work to move forward a national conversation prioritizing mental health, regardless of if you're intervening at the structural or the individual level?
Yeah, so I appreciate that question and thank you for having me. If you don't know NAMI, the National Alliance on Mental Illness, we're a nationwide organization. We have chapters in over 650 communities, and we exist. We were started in 1979 and still exist today because as a society, we don't address the causes or the causes of the causes or the causes of the causes of the causes of mental illness. And we exist to kind of fill that gap and provide that support to communities. And, I work at the policy level, so less with the individual. It may have been a good time to get out of politics. You may not regret that decision at this point in time, but it's a interesting time. There are a lot of solutions. We have evidence of what works, but we often abandon it before we can actually get it implemented. One example, early episodes of psychosis, often hitting teenagers, 20-somethings. We have a model that we know works. There was a groundbreaking study at NIMH, RAISE, Recovery After Initial Schizophrenia Episode. We were able, through public policy efforts, to spread early psychosis programs across the country. There's now over 300. We're still only meeting 10% of the need, maybe 15%. We know this works. We know it improves outcomes for the individual. We know it gets them back connected to work and to school, connected with their social network and their family, leads to better long-term outcomes, reduced hospitalizations, but we don't provide it to everyone who needs it. We don't fund it. The incentives for insurance aren't there to provide the supported employment and supported education because they focus just on healthcare. There are too many times in history where we have seen things that work, that help people, but we don't follow it through to fruition. I will say a more recent example that I think is more of a success story, but is much more downstream, is 988. You talked about incarceration. We see high over-incarceration of people with mental illness, often because of the symptoms they're experiencing. 988 was created. How many of you know about 988? Okay, good. I would expect this crowd to know about it. The National Suicide and Crisis Lifeline went online 2022. More than 14 million people have contacted 988 in that time. And it was meant to be the starting point of a larger crisis continuum. And for the first time, we've seen massive investment that's a shared federal and state investment in a system and really building it out structurally so that we have mobile crisis response for people in crisis. We have crisis stabilization options in communities for somebody who's in crisis. We don't want anyone to be in crisis. We want to help people much earlier, but we've seen it can be done. We can share responsibility at a federal and a state level. We can implement this community by community. And it's an example of like where we're not taking our foot off the gas here. We're continuing. This has been a priority for NAMI. This is a safety net. We hope that this helps us build more upstream services to intervene much earlier, but we know we can do it. We know we can get these investments. We know we can get community buy-in. So why aren't we doing it for other earlier interventions that help people? I do think there's a lot of bipartisan support to do this. I know you're talking about that, so I don't want to steal your thunder. But we need to make the investments. We make these investments first. We save so much in lives and proved outcomes, but also costs. We save so much money as a society when we're not paying for hospitalizations, we're not paying for emergency department visits, we're not paying for incarceration, and we're giving people better lives. We're saving lives. So there are models out there. We know what works. We're just not investing in them.
Terrific, thank you. So now, Dr. Castrucci, we would love your perspective on bipartisan approaches to addressing mental health. So how have you seen the conversation on mental health evolve over time, and what strategies and opportunities do you think that we have to bring together both sides of the aisle?
Seems odd to be talking about bipartisanship right now, but we'll give it a shot, right? This is about narrative, right? And what we've heard today is how we understand, just talking about the social determinants of mental health changes the narrative, right? We always talk about health care in this country. We're going to talk about mental health care because we believe that we can treat our way out of our problem. But you can't. America makes you sick, right? I mean, that's just the way it is right now. And we all have different levels of ability to deal with that sickness. Some of it puts us off a path. Some of us are able to deal with it. Let me tell you a story. Valentine's Day 2022, my wife was mad because we had no plans. And I said, well, why don't you take me to the ER? I think I'm having a heart attack. I had congestive heart failure. I had an ejection fraction of 34%. Normal is 60. My blood pressure was impressive. And so once I was fine, I got my stent and I was able to get out of the hospital. My wife said, hey, you almost died. Why don't you go talk to someone about that? And here I am. I am a relatively well-off straight white guy living in the suburbs of Maryland. And 3 years later, I have yet to find someone who can see me. And I have all the insurance and I have all the privilege because we're not going to treat our way out of a mental health problem. We're going to have to be thoughtful. We're going to have to work together. And hopefully we can use data that comes from CLIMB to say, look, this isn't a red problem. It's not a blue problem. Mental health is purple. We now have the fires in LA. They're behind us now. They're off the front pages of the media, right? So I guess that's all solved. But what about the long-lasting mental health issues around losing your home, not being able to go to school? I am presently in Rockville watching my daughter's friends move away because losing your federal employment will cause you to not be able to pay your mortgage. When something like a job is taken from you suddenly, mercilessly, without dignity, that creates a mental health problem. America makes us ill, and only we collectively can stop that through better policy, through thoughtfulness, through thinking about how we move resources effectively. And I appreciate the kind of the clinical issues that we have to deal with, but an internal focus is just a hamster wheel, right? Whether it's mental health care or health care itself, physical health care, it is absolutely a hamster wheel. And you get sick because of where you live or because you've lost your job and they send you to the hospital, you get better, we patch you up, and we send you back to the thing that made you sick in the first place. We have to break the wheel. Policy breaks the wheel. And we need to understand that mental health isn't my issue or your issue, it's our issue. As mental health challenges have increased, as the morbidity has increased, as the prevalence has increased, that means our employers are on the front line dealing with this, and they don't know what they're doing, right? Our churches are dealing with it. They don't know what they're doing. We need to fund this, not for the individual, but for the collective, for the strength in our society, right? This is, such a cute slogan. I wish I thought of it first, but we should make America healthy again. America's not as healthy as it should be, mentally or physically. I just see a very different way of getting there than our current secretary. And so what we need to think about is how we build America, how we build an America that allows everyone to achieve their options, both physically and mentally. And hopefully, because of the data that we have, we can make this argument. This is what I'd want to go on the Joe Rogan podcast and talk about. So if Joe Rogan is out there listening, have me on. Let's talk about mental health, because we're not going to agree on measles vaccination. We're not going to agree on COVID, but maybe we could agree here, right? Because we all know somebody. Was it 1 in 3 Americans know someone who has been lost due to the opioid epidemic, right? Somewhere, and you don't think you have anything in common with someone, ask that question. Have you known anyone who's ever died of an opioid overdose? And chances are someone's going to say, oh yeah, me. And it's going to cross lines. But we're going to have to change the narrative in this country, because we are right now moving apart from each other. We need to find those issues where we can move together. And that's when we're going to actually make America great again. That's when we're going to make America healthy again. That's when we're all going to get the country that we deserve, not a subset of oligarchs somewhat found themselves in D.C. all of a sudden. But everyone should be able to enjoy the benefits of this country. Everybody should be able to go to work, should be able to overcome and actually not even be exposed to the various structural determinants of health, right? That's the country we have to work for, and we'll have to do it by changing a narrative, working with people from other sides of the aisle, and trying to get through the mess we have right now of major politicization.
For thinking about policy change looks at the intersection of both evidence and values. So we need both of these in order to move forward a public conversation. And my hope is that we will continue on this panel to talk about both the evidence and the values. So Dr. Shim, I'd love to ask you to tell us what you find to be the most compelling evidence. So what evidence has convinced you the most, or do you think is the most pressing as we consider economic policy, for example, and other upstream policies to improve our mental health?
Yeah, these are challenging issues, and it's a great question, and I am going to answer it. But so much was generated by this discussion here, and I just want to kind of just state one thing that I think is, I would call it the elephant in the room that needs to be stated, is that there was not really a time in this country where we were healthy, right? And similar to thinking back to when we were great, there really were no times like that. It is hard to kind of move forward with like a narrative of this country without acknowledging the role that structural racism has had in this country. And I think because this is not something that is bipartisan, is agreed on in any sort of bipartisan way, it becomes very challenging to move forward. Now, there are other countries that have had deep examples of terrorism led and visited upon members, citizens of their country. I think that, Nazi Germany is a really good example of this, and the amount of time and energy that Germany has spent teaching their young people about the Holocaust, talking about the trauma that Jewish people experienced in that country is necessary. And that is not something that we feel compelled to do in this country. We have a massive indifference to the plight of Indigenous and Black people and what has happened to them historically in this country. The reason that I have to bring this up now is because you can draw a straight line to how Black and Indigenous people have been treated in this country, all the way to how people with serious mental health problems and substance use problems have been treated in this country. You can draw that straight line. It is a very easy connection. And anybody who doesn't think that there's a connection there, you can see right now in our current political climate how easy it is for anyone who thinks that they're not at risk to be at risk. It is very easy if you think, oh, I'm not part of that group, so I'm okay, that Black people, Indigenous people are the canaries in the coal mine in this country, to quote Heather McGhee. And so people with mental illness being a marginalized population, people with substance use disorders being a marginalized population, they also are at risk. And so the reflection of this terrible system that we have is by design. We have designed this system to treat mental disorders differently than we treat physical health conditions. We've designed a system that treats people with substance use disorders differently than other medical conditions, and we've done that very intentionally. And so we have to grapple with that before we can move forward. Okay, so the policies that I think are most relevant, I believe that, and it is a health in all policies and a mental health in all policies perspective. It's not about treating mental illness. I don't think the policies that are going to be most effective are about treating mental illness. I don't think they're about treating substance use disorders. I think the policies that are going to be most effective are economic investments. So the data shows, for instance, that income inequality is directly associated with poor mental health outcomes, and in particular, depression. And some of the first people to point that out was Richard Wilkerson and Kate Pickett in their book, The Spirit Level, which I think is a must-read for everybody about income inequality. That was published over 20 years ago, but almost 20 years ago now. But that study about income inequality and depression has been replicated over and over and over in the research. So it is a very well and clearly defined thing. And so if we know then that places that have higher income inequality lead to higher rates of depression, which is the most disabling mental health condition in the world, the most disabling condition in the world, physical or mental. And if we know that those countries that have higher income inequality, and even those states with higher income inequality have higher rates of depression, then one of the most important interventions we could do is, what are the policies that we have that eliminate income inequality? What are the policies that we have that promote and help eradicate poverty? So something like the child income, the child earned tax credit does wonders for mental health outcomes, not just for that family, but also for that child, for generational impacts going forward. So these are very specific policy outcomes that could have massive implications for the mental health. And I really appreciate Dr. Castrucci's discussion about America making you sick, because it is the policies that we have consistently elevated policies that promote and benefit a very small few in this country. And we have implemented policies that punish and harm the overall masses. And that is what's leading to mental health problems in this country. I'll stop there.
Thank you, Dr. Satel. Well, I find myself saying again, there's a lot of truth to that. And these aren't competing visions. It's just that at the level of when a person's in a room with you, that's at the level of the individual. And you could listen to this kind of conversation and kind of forget that people do have agency, even though I understand all the frustrations. And it really is a kind of a tension between, working with folks to, feel more empowered to get out there and, integrate more with society. And then, there's the only job they can get is, like just lowest wage, kind of job, or they can't, or housing situations are difficult. So again, these are, I'm not going to deny for a minute that there are these external problems that folks have to face, but I talk about a narrative at the level of the individual, which is different than the narrative. These are parallel processes. The narrative at the level of the individual is to, again, I think, inculcate the sense of, unless you are just profoundly mentally ill, and even then there are sheltered workshops and all kinds of ways for people to be active and socialize with other folks, but is that again, it's still your life, and we have to figure out a way for you to improve it, while again acknowledging that these other problems exist. So, I mean, here's just one. Well, I'll give you just one little vignette, but then I'll give you a policy thing as well. So today, I am a big believer in the geographical cure, and some people think that's too superficial, but I think it's really profound. That when you change your environment, you really can change a lot. When it comes to drug use, I mean, one of the most obvious changes are you're simply not around the people, the social networks change. I once did a group with some folks, and everyone was saying how once they deleted all because the classic people, places, and things, it sounds like a cliche, but it's really profound. And they used to go through their cell phone and scroll like this to see all their friends, and by the time we were done, it was one scroll, because they just had to. And so today this patient said he's 60. I mean, the average age in the clinic is 57. I mean, these folks have been doing this for a long time, and fentanyl scares some people, but not enough. And now that we have Narcan, which is fantastic, obviously I think it's probably the major reason why the death rate has fallen about 24%. There are other factors, but that's where my money is on. It's the biggest factor. But anyway, he still couldn't. He just could not stop, even though he's on methadone. And methadone is, it's always better because you're in the emergency room fewer days. You're working, even if it's under the table, a few more days. You're less likely to go in the emergency room or get arrested, less. It's all great, even if a person doesn't stop. But of course, that's what, that is the goal. That's an aspirational goal. And so thank goodness, he has a sister with whom we didn't burn that bridge. And she lives out of state and really wants him to join her. And I actually think, you don't just say, oh yeah, do it, but that becomes really part of a therapeutic intervention, is for him to think through the pros and cons of doing that kind of thing and how it would work. And it's all very granular, but that's, that's my chair here, is a granular chair. If I want to get to a higher chair, then I would personally, if I had to pick one policy that's still clinically based, I would say to remove the what's called the IMD exclusion. And this is again more for severe mentally ill people, but also often there's so much comorbidity with dual diagnosis with substance abuse that it kind of captures both populations. But people who have chronic psychotic illnesses, who do sadly commit a lot of horrible crimes when they are on drugs and or floridly psychotic, and who just can't really function. They represent so much of the homeless population. And these I'm sorry, I should define it, but I think you probably know, Institutes of Medical Disease, which I think since 1965 was part of the Medicaid. Yep. The whole idea was to deinstitutionalize and not recreated by having other kinds of institutions, maybe smaller scale, but not greater than 16 beds. That's the cutoff. If it's a hospital or a facility that has 16 beds or fewer, then then they can get Medicaid coverage. But if they're larger, then they can't. And we have so many people who are just suffering so profoundly with such severe illnesses, and they don't take their meds, and they're homeless, and they're estranged from their families, and when they're homeless, they're usually the ones attacked. They're not being the aggressor. And it would be wonderful. It's so important, and this fight's been going on for like 30 years to get that policy changed, so that there'd be a venue, longer, probably maybe the day after it was passed, a venue for folks like that. We've got more meds now. They're not great. There is no great, there's never a magic bullet for anything, but we do have somewhat better meds now, and clozapine is never used enough, and that could really, because you need a blood test, but now you don't need as many blood tests as they used to think you needed.
Not anymore, yeah.
I did that yesterday.
Oh, is that recent? Because I know that
yesterday.
oh, well, what a coincidence. So anyway, that's my vote.
But I would just also, sorry, I know, but I would just also add the fact that we have a drug that's very effective to treat schizophrenia, that we put all these restrictions on and made it almost impossible to access when it is it's no more dangerous than any other drugs out there.
Maybe more
It's just
effective.
another
Yeah.
example of the discrimination of policies that are specifically
It's
focused
our
on.
profession that had a lot to do with it, right? In terms of probably
I
not
mean,
doing.
those were like FDA and,
Oh, I know,
and
I know.
policy level decisions. And that's not how clozapine is regulated in other countries.
Oh, I know
It's
that.
regulated that way here.
I appreciate that, but I meant our folks, NIH probably or could have done a lot of that
They're not my
research.
folks. They're not my folks, but no, I
Yeah.
understand what you. I understand
Just
what you're
do
saying.
that research.
I'm saying there are a
Make-
lot of policies that are specifically made in a way to discriminate against people that are specifically there for no reason except. And it's actually just to take this one step further. I'm sorry, I don't mean to.
She wanted a
this
conversation.
step
It's a
to
conversation.
Take this one step further. Like another example is methadone, and the fact that methadone clinics, in fact, have this requirement that you have to go in every single day, whereas Suboxone doesn't have that
Yeah,
requirement.
yeah.
And Black people are more likely to have methadone, and white people are more likely to have Suboxone. Here's another discriminatory policy that is specifically set up for particular populations that kind of leads to differential outcomes. And then we're kind of like left wondering why we see inequities in different populations when the policy was designed very specifically to create that.
Can I say one thing? Just as a matter
Yes,
of,
and then
of
Brian.
information for folks, because I know that not that everyone. There has been some learning, and the pandemic had a lot to do with it in terms of people. There's now a lot more lenience about when we can start getting people more take homes. So ideally, you come if you're doing well in the clinic, you come once a month, and not just like the methadone, buprenorphine person. So there's been progress there, actually.
Can I have one thing on clozapine?
Yes,
So-
Dr. Castrucci.
So clozapine for treatment-resistant schizophrenia, and to your point, for almost any other medication, there are side effects and often very serious side effects. But we trust people to have conversations with their doctor and make informed decisions in a shared decision-making framework. We don't trust people with mental illness to do that. And we've taken that dignity away from people with mental illness. So, the decision this week is a step in the right direction. There aren't a lot of truly effective treatments out there. We need to make sure that those that are effective, people can access, and that we're not creating these barriers and not trusting people and giving them the dignity to be informed about what they are doing for their own health and well-being.
15-minute visits.
Because I
And
just
that's another huge.
for the audience, and then we'll go to you, Dr.
Yeah.
Castrucci. For those who may not be aware of the policy change, could you please just give us a brief summary of the change this week?
Yeah, so the FDA on Tuesday basically said there's this process, REMS, for risk mitigation. You had to get blood draws if you were taking clozapine at a regular interval because there's a small chance of a side effect. People are on this for years and are still getting these blood draws. That's a huge barrier for people to be able to get the medication. This week, the FDA said that they are not going to require that risk mitigation practice any longer.
And who was fighting us at the Laboratories of America, probably.
I don't know anyone who was against it, honestly.
I mean, I wouldn't be surprised if that's talking about structural, but I mean, that's one reason why it took so long. I'm sure it's rarely monocausal. It's your turn.
Just to draw this, together a little bit. You said that, people have agency, which I totally agree with. I just want to add differential in there. People have differential agency. My agency is different than someone else's, and it could be economic, it could be structural. Let me tell you, if you really want to understand all this, get sick for a week, like really sick. I learned more my week in the hospital than I had learned in all of my training, right? I don't necessarily recommend it, but I never worried. I didn't worry. I was in the hospital waiting to get moved to a different facility to do my stent. And I was out a week. And I never worried about my pay. I never worried about what was going to happen. I never worried about my kids. I didn't worry about anything. I got to experience a health issue without worry. That's my differential. Now, the guy next to me, who I got into a fight with the cardiologist on his behalf, He needed to do a stent that morning, and he ate breakfast. You can't eat breakfast if you're going to get a stent. And the cardiologist came in. He was a man different from me. He was older. He was a different race. We had talked a lot that night because you're in a room together and you both think you're dying. You have a lot of good conversation. And so when his doctor came, cardiologist came and said, "What did you do? You ate breakfast." I said, "What do you think? He went to McDonald's? You brought him the breakfast. You brought him the breakfast. You put it down and he ate it." I have the ability to see because I have the education. I don't have worry. He didn't even know why he was there. No one had explained it to him. We have differential, right? We have differential agency. And that's the narrative we have to change because the agency narrative in America kind of undermines a lot of what we do. Pull ourselves up by your bootstraps. You have control. You don't have control, right? You were born into a situation, and that situation begins to dictate your life. And yes, some people overcome that. Some people don't, right? The thing that I try to explain to my kids is like, oh, well, Dad, you got a parking ticket. That's not a big deal. It's not a big deal given the denominator of our income. It is a big deal if that's like 20% of what you make in a week, right? And so this conversation we've had a lot of conversation about privilege in our nation, but not enough conversation about how we mitigate it, right? How we extend it to everyone, because so I appreciate the
What would you expect me to do? That's a question when you finish. Like, how would you expect clinicians to,
I expect clinicians to advocate for structural issues. I expect clinicians to not 93% of our money goes to healthcare. 3% of our money goes to public health. I need clinicians. Let me tell you what you have that I don't have. You have that white coat. I have worked in public health for 30 years. I wish we had something like, I don't know, a purple hat or something, so that when I walk into a legislature, then they look at me and go, "Ooh, he's the purple hat guy. We got to listen to him." Those white coats. And if you look at Paul Starr's Social Construction of American Medicine, that was about how medicine put itself onto a pedestal. I need medicine. I need AMA. I need pediatrics. I need the entire medical industrial complex to start to recognize that these are not issues that we can treat our way out of. All of healthcare has now said, we're going to take care of your housing. We're going to take care of your food. We have Rush Hospital saying it cured hunger by opening up a clinic, a food bank in their hospital.
I'm not disagreeing with that.
Right. And I'm just saying,
yeah. I think that's
it is, we keep saying like, these are an and, right? I love when you said that. You said like, we're not different, we're together. The problem is though, those of us who have this belief don't have the same power and privilege and funding that the medical and psychological side of it has. So how do we mitigate that? How do we change the focus so that we're looking at structural determinants in a more holistic and consistent way?
This is an
Yes, you can respond, and then we'll.
Catherine wanted to fight the debate. So, like,
It's really
to
wanting
go back and
live
forth.
conversation, and I'm thankful that we're engaging.
But it's an interesting debate because I do think that, and I'm sure we disagree. I don't disagree with everyone, a lot of us in the room actually, because I think when we as doctors with our white coats, I think it is within our purview to make sure that policymakers know that kids living in housing with roaches, that's going to make their asthma a lot worse. I think they should know that. How much we should take on as doctors, not as private citizens. Some of these policy debates, I'm just not sure. I think that, and where you draw the line is tough. I know that, but I kind of think of us, or myself and my colleagues, being more involved with what I'd call health near kinds of policies like the IMD. Like what's closer, what's more proximate to the people I'm dealing with, as opposed to, I've seen articles about, doctors should get involved as doctors, with the electoral system and income inequality. I know you disagree, but that's not my area. We have to stick with our expertise, I think, because policymakers, in my experience, don't welcome doctors going too far. Yeah, the phrase is out of your lane, but it's true. And there's a lot of wisdom to that, because we only should talk, I think, largely about what we where our expertise is. We can't dilute our focus so much. And I think it's an abuse of our moral authority to get too far upstream. I know you disagree wildly.
I strongly disagree.
I know.
But I do think that there is I do think if I'm gonna listen for something that I can find agreement with you on, it is that as it is now, it is not the area of expertise for doctors. But that is a problem. So I actually think, and I actually spend my time as a psychiatrist teaching medical students and teaching residents how this is something they have to have expertise in. They have to become experts in policy because the current way that we are operating is not working. We are not actually helping our patients get better. And you can treat, and you and I, because we're both practicing clinicians, we can treat every single patient that comes before us, and we will not make even the slightest dent. That will matter to that one person. And it's important for that one person and their family, but we will not make the slightest dent in the problem in this nation and in the crisis that everybody likes to talk about around mental health and mental health youth crisis and all of that. We won't even put a dent in that. And so I do think that it is not our expertise. And that is why it is important for doctors to learn about policies, for them to understand this information so that they can go to their lawmakers and advocate on behalf so that we can make these changes.
I do just want to call out for the health services research doctoral students in the room. I believe you just had a conversation about this 2 weeks ago. So we're thankful now to have the opportunity to see physicians share their own thoughts. So continue.
Well, I mean, but we can go further. I mean,
And I do have questions from the audience when we'd like to move on to that.
you know, you had talked about norms, right? We need doctors to start adding to the fray of like removing transgender ideology from surveys. Not because I'm not going to tell you if or what my ideology on transgender is. I am going to tell you though, if you are transgender, you have higher rates of certain diseases and higher risk of mental health. So it's not about a social wokeness that I have. It's about the basic epi and not taking away from me important variables that I need to treat and have policy at a population level. I mean, just from a norm.
Can I just add one thing to that? I'm sorry, you're about to make a really good point, but I just want to say that particularly the data on transgender youth in particular says that those transgender youth, so yes, transgender youth have higher rates of depression, higher rates of suicide, higher rates of anxiety, but those transgender youth that have family members that support them do not have higher rates of depression, do not have higher rates of suicide, and do not have higher rates of anxiety. So here is a family being supportive of them and their identity, helping them protect a protective factor against mental illness, which is huge, right? So absolutely, those policies are damaging the mental health of a whole community of young people. Sorry.
And no, I just, on the norms piece, I always like to make this point. You know, America leads the world in robot tourism. Did you know this? Remember a couple of years ago, we built a rocket, we built a robot, we put the robot on the rocket, sent it to Mars, and it took pictures. Remember that? Like when your grandpa went to the Grand Canyon, you know, and we all just sat around and looked at the pictures. Remember that? We did. What did that take? Yeah, it was the Mars rovers. Amazing. Yeah. Like, what did it take? Think about the intellectual capacity, the money, the political support to do that. That's amazing. We did that. America did that. That's amazing. But we can't find the damn kids who have asthma living in the same apartment building because the property owner has let the HVAC go to shit. We don't make that decision. That's where our norms are jacked. We decided instead of getting every kid into a housing that they could be supportive of their health, that we could look at like the HVAC and we could have a whole national program to change out all the bad HVACs in all the bad apartment buildings. We chose to send a robot to Mars. And just be clear that, listen, you want to make these choices, make them, but be clear about what you're saying. Yeah. Be clear about the fact that we live in a country where we're going to send kids to bed tonight hungry. We've made that choice and we're somehow okay with it. And so what I need from clinicians is the same thing I need from engineers, is the same thing I need from mathematicians. I need someone to say, this is bullshit. And I know I'm at Hopkins. I'm swearing at Hopkins. like
better you than me.
Ellen McKenzie's never going to have me to the main campus. They're going to let me in Baltimore. But come on, We sit here very politely and have this conversation. But this is a conversation about the safety, security, and economic prosperity of our nation. And we are gambling with that right now because we are choosing to bifurcate in our society by further pushing out those who have and those who don't. And that's what's dangerous.
Can I add one thing?
Yes, and then
Sorry.
I'm gonna help us pivot.
So, I mean, I think the point here is that we only address the symptoms. We don't address the causes of our mental health crisis, youth mental health crisis, et cetera, opioid crisis, suicide crisis, all of those things. We're only treating the symptoms. I talked about 988. I've worked a ton on it. That's a symptom of not giving people mental health care. IMD, that's a symptom. We should be so far upstream. As a society, our incentive is to address the short term, what's in front of us, and not get further upstream. How can you take care of your mental health if you don't have a roof over your head or food in your stomach? You can't take care of it. You can't focus on that. And so, you know, I'm all for, we've got to treat the symptoms of it too, because we're here and people need help. And we support that. And that's a lot of what I work on, but we also have to treat the causes, and we're not doing.
Can I pivot?
Oh, yeah.
Okay.
So we'll come back.
So Dr. Josh Sharfstein has written about the importance of telling the story of public health and telling the successes of public health. So we are really good at identifying the problems, the challenges, the deficits. And I wonder if we can help that narrative today by thinking of the policies that did work. So what are the programs that are successful? What does the evidence show that we don't want this program to go away? Do you each have examples of policies that were successful in improving mental health and you think we should hold on to? They can't go away. How can we do a better job of using this platform to herald those successes?
I mean, I could come up with a number of them, but one that I think is huge is Head Start, for example. So any type of early learning intervention, the data on this intervention is overwhelmingly positive. It leads to better mental health, better employment, better income rates, less incarceration, all of these things 40 years out in the future. That's how long it's been studied. And it makes no sense that it is not a universal policy for everybody, but for the people that do have access to it, it is very effective, very a vital policy for those communities. And so success, but also can we expand it and make sure that everybody gets universal pre-K or some type of intervention like that?
Okay, I'm going with education. And the kinds of schools that we should have more of, which small learning groups and more school choice. But that's where, I mean, if I had to focus on one thing, and I know that's what all people who give money away say, is, but I'm not giving money away, but would be there. I mean, you want to start, you identify almost like step one in terms of just the age trajectory. So step two would be just a much more refined and rigorous learning environment for kids. And to you know, if it means having to, I spent a year in a small town in Ohio, so there has to be a place for a lot of these kids to go afterwards. I mean, none of this is new. I'm sure you've all heard of know about these programs, but talk about scaling that up. That's doable. I mean, at least it doesn't require any special knowledge. It requires a lot of will and resources, but that's where I think that's so important. And you're right, you want to avert all this thing. I happen to think addiction is a symptom. I don't think it's a disease. I think it's a symptom. And but I can't deal with, to the extent that it's a symptom of living in an environment that seems rigged against you, hopeless, whatever, you don't see much of a future. I'm sorry, cannot do anything about that sitting with you in a room. But I can discuss my theory of addiction to people, or I mean, present that theory to people who do make the policy. And there's an internal locus of control. I mean, there are people who have dark horizon addiction and then dark genie addiction. and that's from Anthony Bourdain. I just have.
But I think you two just came together because you're saying you can use your expertise to tell the people who do make the decisions about what will help. So I think
That's my, that is my job.
I don't think.
as a clinician, advocate.
I don't think we should.
I'm gonna go out marching as an individual. I'm not gonna get out marching as a doctor unless it's about vaccines or something that is so intimately directed to health. Because that's where my authority
It's all
is.
intimately directed to health.
But Ruth,
All
there's no
intimately
doctor
directed
is
to
gonna
health.
have the level of the deep level of expertise that they need to help policy make direct. And I don't
If-
want them
if they
to. I
are
want
taught- if
them
they
to
are
learn
taught
more
that-
about psychiatry.
If they are taught that, they will have that
Can
expertise.
you teach
What
that?
we decide to teach in medical school is we have agency over that. What we decide to teach in medical school is the agency of physicians.
Yeah, well,
it's
I
the
disagree.
focus
I
here.
don't want
We're-
classes on that. I want people to know how to read a public health paper in epidemiology and the new drugs and,
But
know.
you're, no one's asking the clinician to solve this. It's a change of a
Good.
mental mindset. We view health as simply in the walls of a clinic. We are not like we had a phenomenally interesting project in our Build Health Challenge, Bold Upstream Integrated Local Data Driven. If you've never heard of it, Google it. And it was about a kid who was having asthma, and he was in a home, and PBS NewsHour was there. And we were actually going to talk about how the housing actually impacted the kid's asthma until the superhero came in, the physician. And the physician came and said, let me handle this. It was a whole story about the physician because media and America put everything through a medical lens. Hold on,
Yeah.
let's have a fun game, okay?
He's gonna
When you-
vote and
when-
then he's gonna
right.
wanna vote. And
No, but to do this fun game with me, okay? If you figure out what I'm doing, I want you to start yelling out answers, okay? Doogie Howser, St. Elsewhere, ER,
Dr. T.
Chicago
more
Hope.
interesting than you are.
Wow. No,
More
they're
cinematic,
only more
aren't they?
interesting.
shows, hero Dr. TV shows.
Hero doctor TV shows. And so it has to be a changing of our American consciousness that health starts in the community. Health starts not in, because everything it's someone comes in and they're dying and then George Clooney saves them and it's fabulous. And so that's how we understand health. We acculturate ourselves from the minute we're born. I mean, Doc McStuffins was right? We all know Doc McStuffins. Doc McStuffins is a Disney TV show. It's a young girl who puts on a coat and it makes a little sound, and then she can solve every problem because she's a physician. Instead of we can solve our problems. You know who can actually have more impact than all the physicians in this country combined? Are elected officials if they actually decided to make the right policy. So I'm with you. It's not on you. It's on us. It's not me. It's we when it comes to fixing America's health problems.
Aren't you encouraged that it seems to me the newer generations of medical students and residents are.
I'm old, so out of my generation.
Well, I'm older than you, I think, but I'm just gonna say that I think that you wouldn't, I think you'd see more enlightened clinicians in the newer ranks, don't you think?
I teach them. I'm very inspired.
And even outside.
I'm very inspired, and
University of
I teach them, and
California.
I know the reason I do the work is because I know that they are going, and I say that it's not my job to fix it. This is where you and I agree. It is not our job to fix this problem, but it is my job to make sure that my students and my residents truly understand the scope of the problem so that
I agree with that.
they can solve this problem, because this is a generational level problem, and they are going to be in positions of power 20 years from now, and they will make different decisions because they have the knowledge and the expertise to talk to the politician, to push the policy and to make decisions at the academic health system level and at the high level health system level that will actually lead to the change that we're talking about here.
And the hope I see is actually talking to my kids. I got a 15-year-old and a 13-year-old. How they talk about mental health isn't
Completely different.
anywhere near the way I used to talk about, like when I was that age. They have conversation. They are sharing. There are procedures in school which we never had. There are interventions so that if you're seeing an issue amongst one of your friends, it's not that, so-and-so passed away from unknown causes. Like, well, yeah, we all know what those unknown causes are. We're not talking about them. They talk about them, right? And I even bullying, like this is not a great thing, but I mean, I look at one of my son's friends, and I just look at him and I think, dear God, you would have been bullied mercilessly when I was in high school. Like every aspect of it just would have, and he's like the most popular kid in school. I'm like, thank God y'all have evolved in this over where the Gen Xers are, even though Gen X rocks. We had some challenges in how we, dealt with mental health. We did a suck it up buttercup kind of way, and that's probably responsible for some mental health issues in people of my age. But that younger generation is talking more there. And I'm even seeing over the last couple of days, this is interesting, as I scrolled mindlessly on Reels, a conversation that was emerging in a couple of influencers around high functioning depression. I was like, wow, I hadn't heard that term. Wow, now it's on Reels. And now we can talk about it, right? The role of influencers, not even physicians, the role of influencers in our society to talk about mental health and have a positive mental health image. I think that's really important as we evolve collectively as a people.
Oh, did you have questions? Yeah, so this is a perfect time for you to take out your phones, go to the QR code, and submit questions to the Slido. And now I will start asking questions that have been submitted, even though I've tried to incorporate some of the questions throughout. So this question is, in a time of budget cuts, how does investing in economic intervention to help mental health outcomes become a budget priority?
If you figure that out, let me know. No, I mean, here's the thing. So it sounds weak to say this, but the last few years where there have been more and more budget cuts in many areas, we haven't seen it in mental health. Well, we haven't seen increases. We saw big increases at the beginning of the pandemic, but it stayed flat where everything else has been cut. So we're trying desperately to hold on what we have, but we've underinvested in mental health forever. You say for decades, but really forever. We've never invested what we need to in it. I think the one bright spot is that the pandemic actually made mental health relatable to policymakers. They saw it in their families. They realized, oh, this touches the people I know. This isn't somebody else's issue. This is my issue. And so I think that has been helpful in kind of protecting funding. I think where we have the real challenge is investing in affordable housing, protecting SNAP benefits, doing all of that. That's our real challenge right now. And I don't know what that answer is. It's going to be increasingly difficult to keep those protections. And I fear what that ripple effect is going to look like and where we're going to be in 1 year, 5 years if we don't hold on to that.
It's prioritization, right? I mean, what do we spend? We spend more in the military than our next 26 countries combined. And so we're still no one talks about military cuts, right? So it's prioritization and showing that there's an economic benefit to affordable housing. But again, there's someone, again, I was watching on TikTok, and it was a conversation about student loan debt, and said, I didn't get student loan debt, so I don't want to be there for the bailout. Well, I wasn't there when we bailed out the housing industry. I wasn't there. I didn't own a bank when we bailed out the banking industry, right? We prioritize what we want to prioritize. And in 2008, we bailed out the banks who made a lot of bad bets. And so, but that's okay. That happened. But when we wanted to bail out students from having, crushing student loan debt, that's not okay. So it's, what it gets down to? It gets down to voting, right? It gets down to candidates running. In my hope right now is the Democrat who's running, and I'm a Republican, so I'm bipartisan here. I can say I like the Democrat. The Democrat in Ohio who just announced for governor, Amy Acton. Amy was the state health commissioner in Ohio. Amy Acton knows structural determinants. Amy Acton is the kind of politician we need. We need politicians who understand structural determinants of health, that understand that every decision they make has a ripple effect and that it's an important ripple effect. So we're talking about budgets like it's some sort of zero-sum game. And it's really a conversation about what do we value? And it gets down to, like, again, us having right now very stark differences in our values as a country.
Local versus federal. what hope do you see at the local level?
Well, in California, I see a lot of hope at the local level. So I can speak to the fact that there's a lot of really good work, but I also think, local is where a lot happens. And I think definitely in this current environment where the federal government has basically been really clear about what their priorities are, we have no choice but to lean on our local governments to maybe pick up the slack and maybe focus in on addressing these issues. And I would encourage, if people are trying to do policy interventions, I think right now and maybe for the foreseeable future, policy interventions at the local level are really where we can have a lot of impact.
Well, that's where a good Republican would want it to go. Federalism. So local control. I don't know how coherent the kind of governing vision is right now. It seems to just be real focused on cutting what's perceived as waste, and there is a ton of it. I'm not saying it's being approached the right way, but that is, the kind of the conservative vision to subsidiarity and federalism. Let the people who know their problems best try to solve them. And if they need some help, we don't tell them how to use the money. That we might give them money, we should, but we're not going to micromanage how they use it. How it's supposed to.
I mean, I think local is definitely where change is going to be possible, especially in the next few years. But to the earlier question of what policies have made a difference, so we want to expand the local level, mental health education in schools, making that part of the curriculum so that every kid is like your kids, right? That they are okay talking about mental health. They don't see anything wrong with talking about their mental health, that they support each other, that they know what to do if they're not feeling okay, that they know it's okay not to be okay. Policies like that can really get upstream. Having the ability at the local level to advocate, one voice makes a huge difference at the local level. Having a small group of really motivated people makes a lot of difference at the local level. So I have a lot of hope there that we can implement policies. My fear is that that's just going to spread greater inequity because some communities will be able to invest and others will not.
Your Google homework is to Google cityhealth.org. City Health is a project where we've selected a group of policies. We rate the 75 largest cities in the country as to whether they have those policies. We've been able to move 40, 50 policies over the 10 years that we've been doing the work. We give cities medals. If you want to get a mayor to do something, give a mayor a medal, and then every other mayor wants one too. The challenge is preemption, right? The more progressive that some cities are getting, the greater the threat of preemption from state legislatures. I mean, when you have a place like California that can preempt beverage taxes, you can see the power of an industry working at a state legislative level as a way to kind of bring the locals to bear, right? And they did that because beverage taxes work. And so we have to watch that play between preemption and local control. But in some states where preemption is heavy, we're even seeing pushback from Republican-controlled locals who are like, wait a second, you're doing this preemption, but you're also hurting me. Because we're asking these local leaders to build healthier communities, but we're taking away all the tools that they have to do it. So, but City Health, Google cityhealth.org and follow them because they're actually operationalizing this idea.
Okay, so I've got one more question from the audience, and then I'll do a rapid fire question to conclude. But this question from the audience is, given that we're in DC right now, even though this is affecting workers across the country, many federal workers are finding themselves newly unemployed. How can economic or other policies help the mental health of people in these types of situations?
I think so. There's really, really clear data on how bad it is for your mental health to lose your job, right? Like that's very clear. And again, that was research that we looked at heavily when we were writing the social determinants of mental health book. And so there's just a lot higher rates of alcohol use disorder, higher rates of depression, higher rates of PTSD, and higher rates of generalized anxiety disorder are just some of the things that you see with unemployment. But so solutions, I think one is that this country is far too reliant on a capitalistic model for how it operates, and that means that workers are not valued in the way that they need to be. So revaluing, like changing that structure so that work is valued and is given more value, and like the actual act of being a worker is far more valuable. And so there's lots of examples of how that works in other countries and in other spaces where you can have employment opportunities where it's not like you lose your job and everything is a mess. But we are in a capitalistic society. So in this society, what we could do in this society to try to mitigate some of the impacts, the negative mental health impacts of unemployment, would be to have generous unemployment benefits so that people could have the time and the energy to find other jobs and not have to worry about not being able to pay rent and not being able to support their children in daycare and all of these things just because they lost their job. That is something that other communities and other countries do very effectively. And they don't see the same negative outcomes from unemployment that we see in our communities where people don't get those same benefits, and they really become very stressed and very overwhelmed by all of the additional burden that comes when you lose your job in this country.
Last comment. Again, in parallel, because, but from a clinical standpoint, in a way, this is it's not an exact analogy, but it parallels a little bit, but on a smaller scale. People's reaction to the pandemic in terms of this mobilization to address the mental health situation of people who were really affected by that. And one, this in a way is a Band-Aid, although for a particular person, it could make a difference between staying out of a hospital for, if their depression gets really awful, and being home with their kids and their family, which is that a member of psychiatrists kind of banded together to donate an hour, to do therapy kind of for folks who are really badly affected. In these situations, it's always, it's almost always the idea of getting that other job, being replacing what you lost. But as you say, it is very powerful that losing a job is just mortifying. The only consolation here is that no one could possibly think it's their fault, and that they share that with a lot of other folks. But just in terms of clinically addressing this, I wouldn't be surprised if psychiatrists do try to form those voluntary organizations to help. But as I said, just could make a huge difference for an individual, but that's the problem is much bigger.
You have a lot more faith in psychiatrists. So now to conclude, hopefully on a note of optimism, and only answer in one sentence, and ask each of you what gives you hope as we wrap up today.
I'm going to pass because nothing gives me hope, and it's a longer statement, but my students give me hope, and I'll just leave it at that.
We'll take the students. Okay, the students give us hope. Thank you.
Okay, I know that hope may be too strong a word, but I think this is, I think the new leadership at HHS is really quite radical, and in part that may be constructive, in other parts it's a real challenge. And I think that's going to mobilize a lot of people to figure out, or at least be able to coalesce around things that are not tolerable and things that we do need. And that there will be, I'm sure that the resistance is growing in certain domains, and that'll be, it's kind of exciting. I mean, it's, the whole situation is, it's anxiety provoking. I get it, but at least maybe see some really constructive activism.
Yeah, activism is what gives me hope. NAMI is an organization of lived experience, people with mental illness and the people who care about them. And just the last few weeks, our advocates have made tens of thousands of contacts to Congress. They're fired up. They're ready to respond. They're ready to respond en masse. I wish they didn't have to, but people who have lived experience, who are willing to share their story, often painful story, to help others. I mean, that gives me hope every day. Amazing people that I get to work with who turn their pain into purpose.
There is more that we share in common than divides us. And we need to start seeing more of that. And that's the hope, is that we actually find what brings us together and not continue to just focus on what drives us apart.
Thank you. Well, please join me in giving our speakers a round of applause. Thank you. So this conversation gives me hope, as well as many of you in the room. Please stick around for networking and appetizers. And if you are interested in this conversation, come back. CMAP will be hosting 2 more Nexus convenings, one on March 17th and one on April 1st. We look forward to seeing you there. Thank you again.